Thanks. Oh, goodness. Good morning, everyone. My name is Sara Dugan. I am a mental health pharmacist and faculty at NEOMED. That was a new pop-up for me with the recording, so that kind of caught me off guard. It was much bigger than usual. So as many of you are aware, for our Mentor Echo, we do have a series of rotating topics. This is one of the newer topics that we had added to the rotation to look at adjunctive treatment of opioid use disorder. So the objectives I have for this short didactic session are to list some of the medications that can be used adjunctively. So what are we talking about in terms of adjunct use? To identify the signs and symptoms, so why might we use them? And then we're going to look a little bit more specifically at the potential role that some of the alpha-2 adrenergic agonists could use, so lofexidine and clonidine specifically. So in setting this up and framing it, we really are going to hit on three different categories of treatment for opioid use disorder, both the withdrawal aspect for patients who are in maintenance, as well as those that are in recovery, recognizing that in some cases they may need some of the adjunctive medications to blend not just from the withdrawal, but into the maintenance and recovery phases as well. So recognizing that, the bucket of symptoms that we're really focused on to consider treatment for adjunctive, adjunctive treatment for these patients include a bunch of these different symptoms. So recognizing that there's a huge variability for the patients that you see, there may be different combinations of these that are really problematic for some patients. In some cases, things like agitation, some of the cramping, diarrhea, some of the muscle aches, increased tearing, that may happen really early within the withdrawal phase for some of the patients. Some of the other symptoms that we see here, things like anxiety, some of the cravings, those may really blend into the withdrawal or into the maintenance, out of the withdrawal into the maintenance and the recovery phases. Things like the insomnia may continue to be problematic. So really being sensitive to the fact that we may see some of these much more prevalent in an acute phase of treatment, but long-term, we may still continue to see these for some of the patients. The protracted withdrawal symptoms, and I had looked and still looked and have been relatively unsuccessful in finding, hey, are there really controlled trials and evidence we can point to that show that we're looking at this? But it's a lot more anecdotal, where it's recognized that this definitely exists, but the prevalence of it existing and then what should be our real clear-cut next steps is a little bit more ambiguous. So thus, that's where we came up with this particular topic. So recognizing that's a lot of different symptoms, we do have quite a few different categories of medications that could be adjunctive agents to help with these symptoms for the patients. So the alpha-2 adrenergic agents, we are going to focus on these a little bit later, so I'll hold off on those for just a moment. Some patients may find benefit with things like acetaminophen or other non-steroidal anti-inflammatory medications, things like ibuprofen, if they need naproxen for a short period of time. These may be much more prevalent initially, and then not something that patients will need to continue much into the maintenance phase of treatment. Gastrointestinal symptoms, so really helping support them with some of those GI symptoms that they may experience, things like loperamide and bismuth subsalicylate have been used. The loperamide definitely is a little bit used with much more caution because of the potential for abuse. Our therapeutic dosing of these is much smaller than what is used when it is abused. So therapeutic doses for a short period of time don't look to be problematic, but this might be one where it's not going to bleed over into those other two phases of treatment quite as readily without some degree of concern. Other medications that have been used on danzatron for some of the nausea, hydroxyzine has been used relatively effectively for anxiety as well as for insomnia, potentially irritability in some patients. Excuse me. From an anxiety standpoint, if those are the symptoms that we're targeting, we may be able to use this for a longer period of time. In some instances, it's used as a PRN, so just when the patient needs it. In other instances, it may be scheduled, so something that's given a couple times a day, maybe sometimes just once a day at bedtime on a more regular basis. If we're really targeting the insomnia, this does tend to lose some efficacy after about 3 to 4 weeks of treatment. A patient becomes tolerant to those sedative effects, so it may not continue to be effective for that. But for some of those other symptoms, it may continue to have some benefit for the patients. And then other anticholinergic agents, and these may help with some of a whole variety of symptoms, sometimes from taking the edge off anxiety to some of the gastrointestinal effects that haven't responded in other ways. So we've got a variety of agents that we could potentially use. And in a number of detoxification protocols, you'll see all these different buckets of treatment options, but they tend to be relatively short term. So part of this presentation is making sure that we're not saying, hey, we're going to cut this off really early if those symptoms do continue, that it may be for some patients that this is something we need to use outside of just a short 3 to 5 day window. With that in mind, these are some of the ones that have been reported most frequently and the symptoms that they're associated with from that big chart, just to look at it in a little bit of a different format. But I do want to draw your attention to the column on the left with the alpha agonists, because these may help with a number of initial symptoms, but also may assist with some of the anxiety, some of the irritability, potentially some of the cravings. These have been looked at as maybe being able to expand a little more consistently into the maintenance and recovery phases of treatment. And ultimately, our goal is that these adjunctive medications are going to help. They're going to be an assistance device, they're going to be a buffer, a crutch for some of the other first-line treatments. We were talking about adding these to psychosocial interventions, as well as other medications that may be used for these patients. So whether it be buprenorphine or methadone or naltrexone, but really the goal is adding these to the first-line treatments to assist the patients in maintenance of therapy and ultimately to get them to recovery and sustained recovery. So recognizing that those acute protocols, I'm not suggesting that they have to be changed. We do have pretty good evidence for most of those medications that were listed in the short term, but just recognizing that just because that's where most of the evidence is doesn't mean that there aren't patients that may need it a little farther down this timeline, a couple weeks, maybe a couple months, but really being sensitive to that inter-individual variability. And with that in mind, I do want to transition to look specifically at this class of medications, the alpha-2 adrenergic agents. In general, the treatment goal for this class of medication has been described as reducing withdrawal effects, so some of the physical effects as well as some of those psychological symptoms that were listed, and successfully maintaining a patient to start maintenance therapy. So that was where their initial indication was, but we're going to be able to look at a little bit of evidence that suggests that not only getting a patient to start maintenance therapy, but maybe to continue with their maintenance therapy. So the two main alpha adrenergic agents that have evidence are clonidine and lofexidine. Clonidine is off-label use. You could see the dosing recommendations that are here. We do have some adverse effect considerations with the clonidine. A lot of the trials initially were done with the immediate release. So we did see a little bit more in terms of the hypotension as well as some of the sedation. With the longer acting, the extended release clonidine, this is still a consideration, but it may not be quite as prevalent as what we saw with the shorter acting. The lofexidine does have FDA approval. We see our dosing here. And while it has been, the dosing recommendations are for 14 days and then with a gradual dose reduction, it has been used for an extended period of time. And we're going to look at a little bit of that longer term data. These aren't the only alpha adrenergic agonists. These are the two I focused on because it is a didactic blitz. It's supposed to be a short, brief presentation, and there isn't quite as much evidence with the guanfacine or the tizanidine. But I wanted to make sure that we appreciate that these aren't the only two in this class. So do these work? This was a systematic review and meta-analysis, one of the Cochrane database reviews that was done. And it was looking specifically at all of the alpha-2 agonists. There was only, I believe, 1 or 2 trials looking at tizanidine. There were a couple that looked at guanfacine, but the most of the other trials included in this review were the clonidine and the lofexidine. They looked at a number of different outcomes. I pulled 2 in particular, those that had alpha agonists and those that were on placebo initially starting treatment, and whether or not they experienced severe withdrawal symptoms. We see that about 17% of the patients who were treated with an alpha agonist had severe withdrawal, where it was almost 60% of those patients in placebo. And this very likely was one of the causes of the other category that's listed here, the completion of treatment. Most of these trials were relatively short term, looking no more than a couple months. And about 55% of the patients that were in the alpha agonist group were able to complete treatment, and only about 29% of those in the placebo group. So about a third. So we were losing about 2/3 of the patients in the placebo group and slightly under half in the alpha agonist group. So it did look like initially in therapy, these are able to help take the edge off a little bit and help the patient at least finish the first phase of treatment, which is the first step. Some of the reasons, so it's not 100%, it's not perfect. It was only 55% were able to complete treatment. One of the driving forces was adverse effects. So lack of efficacy, withdrawn consent were the other 2 reasons. We may not be able to control some of those reasons. The adverse effects we may be able to do something about. So looking at this class, we did see orthostatic hypotension, where patients' blood pressure would drop with positional change, encouraging them to take it slow if they're rising from a laying or seated position, as well as encouraging fluids, which would be helpful for the patient overall. It can cause some heart rate changes. We do see some bradycardia. It can cause some sleep changes. Many times it can cause sedation. They tend to be sedating agents. However, insomnia is reported in a number of the trials, and it is thought to be more due to the patient being in withdrawal than being an adverse effect of the medication, although they're unable to, more of an association that yes, sleep changes in both directions are recognized, but traditionally it tends to be more sedation with the alpha agonist, and that the insomnia is from the disease itself. Other side effects we can see are dizziness, which may or may not be related to the hypotension, dry mouth, as well as headache. So aside from some of the cardiovascular changes in patients with cardiovascular disease, for the most part, we are able to manage most of these adverse effects, and they do tend to develop tolerance over time. So not a rate limiting step with them. So recognizing that generally well tolerated, something that seems to make patients more comfortable, doesn't make that much of a difference. Is this really going above and beyond? So I wanted to look at first-line treatment for opioid use disorder. So these are 2 different systematic reviews that looked at treatment with buprenorphine and methadone, and then one that looked at treatment with naltrexone. Looking at their efficacy was decrease in cravings and improved withdrawal effects. And what they found was retention in treatment. So with the alpha agonist, we had about 55% were able to be retained in treatment. We're right in a similar ballpark with the buprenorphine, the methadone, and the naltrexone, which suggests that 50% that are withdrawing from treatment from the buprenorphine, the methadone, or the naltrexone, we may be able to impact some of those patients who may be having continued symptoms and need some additional support. So not necessarily less effective than those other medications in terms of withdrawal of treatment, but maybe providing a booster for those patients that were really struggling. So recognizing that, we don't have a lot of data looking at that long-term use of alpha agonists. So adding these on board to an existing treatment. We do have this trial. So it was a randomized double-blind 12-week trial. Patients were outpatient with opioid use disorder already on naltrexone, and they were randomized into 2 groups. So they were randomized either to receive lofexidine or to receive placebo in addition to their naltrexone. They were relatively small groups. The outcomes they were looking at was the adherence to the naltrexone, which we know tends to be a little bit problematic as we go longer term. The number of opioid-free urine samples between the 2 groups, as well as cravings reported from the patients. Now, these patients had an average history of about 6 to 7 years of opioid use. Their use prior to treatment had been about 12 to 13 days a month. Most of them were male, and on average, they were in their mid-20s to early 30s. What they found was not as significant a difference as what they had been hoping for. So in terms of naltrexone adherence, they saw no difference between the groups. There was a slight numeric advantage for the placebo group, but generally they both were similarly adherent to the naltrexone. So between 55 and 60% of patients continued on treatment. I do just want to pause. There was an incentive for patients to continue treatment, so that may have been one of the reasons that we see adherence at about the 55 to 60% mark. In terms of positive urines, 11 to 12% did have positive opioid, tripping over my words here, their urine was positive for opioids. So no difference between those in terms of who was using other opioid substances. The days of opioid use was also consistent, 4 to 5 days for each group, which was a reduction from where the patients had been at baseline, but was still prevalent. And then changes in cravings, we saw a slight difference, but it wasn't statistically significant. So it did look like we had a bigger change in the cravings with the lofexidine group, but not enough to demonstrate a difference. The completer group is where they did see a difference between the 2 groups. So there were more patients in the lofexidine group that were able to complete the trial compared to the placebo group. It wasn't by much, but there was an improvement there. When they looked at this group specifically, they saw that quite a few of the patients who had been randomized to the lofexidine group, and it was 2.6 milligrams, 2.4 milligrams daily, they saw that tolerance was really problematic. Quite a few patients did report adverse effects, and a number of them may have withdrawn or not been quite as adherent to the lofexidine group. So maybe it wasn't a pure treatment group. When they looked at those that didn't report adverse effects, they saw a significant improvement in cravings, as well as a delayed time to return to opioid use. So it was longer without having a positive opioid detected in their urine. So for those patients that could tolerate it and had the naltrexone and the lofexidine added together, it did look like the combination was positive for those patients, and they were better able to manage the cravings, and we did see a little bit of a bump in completion of treatment. So possibly for a small group of patients, this may be something to assist them to keep them in treatment and manage some of those cravings that aren't being managed by their current treatment. Unfortunately, we don't have a lot of other information. There are a couple other trials that are ongoing. We just don't have that data as yet. So to wrap up, the first-line treatments that we have are available, but they may not cover everything. So there are a number of different adjunctive treatment agents that can assist with some of those withdrawal effects. We may have to do a little bit of shifting to individualized treatment for those patients. Our alpha-2 agonist may be a potential option for longer-term treatment outside of just the acute withdrawal phase, although currently at this time, data is limited. Tolerability is a consideration, so we need to keep that in mind and make sure that the benefit the patient is getting is not outweighed by some of the toxicity that they may be experiencing. With that, I will stop sharing.